क्यान्सर रोगको क्षेत्रमा विशेषज्ञता हासिल गर्नुभएको डाक्टर अमिश चौधरीले नेपालको बीपी कोइराला हस्पिटल धरानमा 1 वर्ष आफ्नो अनुभव साट्नु भएको थियो भने उहाँले राजीव गान्धी क्यान्सर इन्स्टिट्युट लगायत विभिन्न क्यान्सर हस्पिटलमा काम गरिसक्नु भएको छ। हाल उहाँ कन्सल्टेन्ट सर्जिकल अन्कोलोजिस्टको रूपमा म्याक्स सुपर स्पेशलिस्ट हस्पिटल साकेत म्याक्स क्यान्सर सेन्टरमा कार्यरत हुनुहुन्छ। यतिखेर भने हाम्रो साथ हुनुहुन्छ डाक्टर अनिश चौधरी। उहाँ सर्जिकल अन्कोलोजिस्ट हुनुहुन्छ र उहाँ म्याक्स इन्टरनेसनल हस्पिटल दिल्ली साकेतमा चाहिँ उहाँ कार्यरत हुनुहुन्छ। यतिखेर उहाँलाई कार्यक्रममा स्वागत गरिहाल्छु। हजुर डाक्टर साहब, वेलकम टु नेपाल।
Yeah, thank you very much.
When you started to come Nepal as a surgical oncologist?
As a searching oncologist, this is my first visit to Nepal. But this is my first visit. But I have worked in Nepal in BP Koirala Institute at Dharan as a senior resident. Way back in 2006, I was there for a year, and there I came to know about the health structure of Nepal. How people used to travel from long places on feet. There used to be delayed presentation. But overall, yes, at that time it was a good experience to work here. So then I underwent training in oncology in Rajiv Gandhi Cancer Institute. Then I underwent subspecialization training in Calcutta. So when I joined Max, our director said that you've been to Nepal, you have friends there, so you can go back to your place. Yeah, it's been a nice experience. I met my friends after a long time.
Okay, comparatively to India, what is the condition of cancer disease in Nepal?
Yeah, the cancer is almost as prevalent as in India. The only difference is that because of lack of diagnostic facilities and lack of a good referral system of cancer, the presentation here is late. Compared to India, the urban settings of India, they are now we are gradually seeing a shift from stage 3 to stage 1 and 2 in our OPD. But in rural India, the situation is almost the same because they also lack early access to the diagnostic imaging. So in rural India also patients come in stage 3, stage 4. It's quite similar to Nepal. Yeah, it's quite similar to India, the rural India.
Okay, and how do telemedicine helps in treatment of cancer disease?
Yeah,
in collaboration to Max Hospital.
Yeah, we are doing telemedicine services with Max across many centers like Uzbekistan. We are having Afghanistan also 1 or 2 times we have done. Then we organized first Indian Cancer Congress in which multiple sessions were given to the audience through telemedicine from high-end research labs in US and UK. Cancer oncology is a integrated branch. Like unlike cardiology, cardiology is one branch, nephrology is one branch. Oncology is a mixture of 3 branches: radiation oncologists, medical oncologists, surgical oncologists. So these 3 super trained people have to come together to form treatment module of one patient. So this is called tumor board. When all 3 people sit together, then decide what the treatment protocol has to happen. In Nepal, it is very difficult to find all 3 together. Collaboration between all 3 is difficult. So what telemedicine can help us is to conduct tumor boards. That one doctor gets one patient and he investigates, and then you can do a tumor board and finalize the treatment across an international protocol, and which can be delivered in your own country.
Doctor, at which stage that surgical treatment is required?
See, in malignancies, we broadly classify under 2 types. One is called liquid malignancies, and the other are called solid malignancies. Liquid malignancy, that is blood cancer and lymphoma. In these malignancies, they are under the ambit of medical oncology or hemato-oncology, in which surgery is never needed. And the other is solid malignancy. Solid malignancies means solid organs like breast, lung, pancreas, cervix, every organ malignancy. They are called solid malignancies. Surgery is an integral part of all solid malignancies. Up to stage 3, surgery is required in all solid cancers. In stage 4, yes, by and large, chemotherapy will take the lead of treatment. But in all solid organs, surgery is the only curative modality.
Okay, then what can be done to get access of cancer treatment for underprivileged people?
Yeah, for the underprivileged people, actually, no single module can furnish their needs. Like in India, we have a strong population of 135 crores, out of which about 40 crores are below poverty line. So we are also struggling with the same issue as Nepalis. So what the government of India and the private players have realized over time is that no single module works. You have to have multiple modules. Like in our country, we have come up with public-private partnership where the land, the equipment and the construction cost is borne by the government, and then a private partner takes over it. He runs the hospital and he delivers about 50% patients free of cost, including chemotherapy in addition. This is one model which is working very well. The other model is to have a super specialists trained by the government in developed countries, bring them back into your country and then let them deliver the treatment in your government setting as it is. The third is the empanelments, that all public sector undertakings as a group, they pay a certain amount, fixed a certain amount to the government, and then those public sector undertakings as a group, they become a bulk consumer or to some 1 or 2 or 3 hospitals for certain services. Like for cardiac, they can tie up with one hospital. So it helps them bring them the cost dramatically down. If you go as an individual to a hospital, see the hospital has many costs to overuse. So if you are a bulk consumer, like if you have say your ex-servicemen, or you have say Nepal police, Nepal army, these if they deposit even 100 rupees a month, so that will be a bulk amount for which all treatment is done. Then the third model is the one which Dr Amish Chaudhary has followed in India. What he has done is, he has insured in whole state, the whole of Andhra Pradesh. He has insured, he collects about 30 rupees per electricity connection from the government. The government pays for each electricity connection in the state, they pay them 30 rupees per month. And for that, and in lieu of that, he does every cardiac surgery free of cost to every person living in Andhra Pradesh. It is free of cost, whether it's a laborer or whether it's a businessman, whatever. He brings down the cost dramatically because he has insured the whole state. So these are the 4 models which are working in India, and hopefully now high-end treatments have reached the poor. Even now you can see in India the most costly treatment, liver transplant, even the poor are getting done.
Okay, then how can we raise awareness regarding preventive measure of cancer?
Yeah, awareness is one tool which is the most cost effective. It is very cheap, and it gives you benefits in long term. The best awareness is against tobacco, and it can be done not by physicians. It has to be again a multi-targeted approach. NGOs, schools, colleges, government organizations, they have to come together. Like we have an anti-tobacco program going on in Western UP, which has one of the highest tobacco incidents in India, where you target the students of class 10 onwards and you teach them about anti-tobacco. Because we have seen generally who do not start smoking till the age of 18, they don't smoke. And those who start smoking before the age of 18, they generally don't quit. So that's what we have seen, that if you target population before, because tobacco is the leading cause of cancer. It causes about 12 to 14 cancers, solid organs cancer in the body. Each of them is highly aggressive. And the other awareness you can about breast cancer should be there, because in breast most ladies come in stage 3, where the survival rates drop down to close to 60%. Whether if you do treatment in stage 1 and 2, if they reach their physicians and gynecologists earlier, the treatment survival rates are close to 85-90%. So these are the 2 places where awareness should be spread more, and which are highly cost effective.
Okay, lastly, any message to our audience, please?
And the message is that you should take your health as priority. When you are aware of your health, your government will. When it's not that the government will become more aware of your health than you will. So remain fit, consult your doctors in case of problem, don't delay, because cancer is curable if it diagnosed early. Yes. If it's late, then you are. The treatment is long. Treatment is costly. The outcomes are poor. And even if we say you have only 20% chance, and your cost of therapy is say 2 lakhs or 3 lakhs, you don't know whether should I say yes or whether should I you say yes or you say no. You lose on both the sides. You spend money, even then you end up with nothing. So yes, you should don't delay your problems. Come to your doctor early. That's it.
Okay. Thank you very much.
Thank you.
Great talking to you.
Yeah, it was a great pleasure.
Thank you.
Thank you.
आजको कार्यक्रममा हामीले इन्डियाबाट आउनुभएको डाक्टर रजनीश मल्होत्रा र डाक्टर अनिश चौधरीजीसँग कुराकानी गऱ्यौँ र विशेषतः नेपाल भारत मैत्री अस्पतालमा र विशेष गरेर नेपालमा धेरै भारतबाट डाक्टरहरू आउने गर्नुहुन्छ, आदान प्रदान गर्नुहुन्छ, आफ्नो ज्ञानको सेयर गर्नुहुन्छ र विशेष गरेर नेपाली बिरामीहरूको लागि पनि सेवा पुर्याइरहनु भएको छ र नयाँ प्रविधिहरूको बारेमा पनि उहाँहरूले आदान प्रदान गरिरहनु भएको छ। यो एउटा राम्रो कुरा हो, तर नेपालमै पनि धेरै कुराहरू इन्फ्रास्ट्रक्चरहरू बनेमा स्किल म्यान पावर अथवा डक्टर्सहरू भएमा चाहिँ अवश्य पनि नेपालले अबको 5 वर्षपछि चाहिँ कार्डियोलोजीमा मुटु रोगमा नेपालमा पनि मिनी एक्सेस इन्टरभेन्सन अथवा सानो सानो पाल पारेर पनि मुटुको समस्याहरूको समाधान गर्ने कुरा डाक्टर रजनीशले बताइहाल्नुभयो र अवश्य पनि चेतना जनचेतना नै ठुलो कुरा हो। यसको लागि चाहिँ क्यान्सरको रोगको लागि होस् अथवा मुटुको रोगको लागि होस्, आफ्नो जीवनशैली परिवर्तन र जनचेतना नै महत्त्वपूर्ण हुन आउँछ। हजुर, आजको कार्यक्रमबाट सम्पूर्ण सहकर्मीका साथ म पनि बिदा हुन्छु। हजुर शारीरिक र मानसिक रूपमा स्वस्थ रहनुहोस्। नमस्ते।
मेरो डॉक्टर का प्रायोजक जगदम्बा सीमेंट।